And we are live, Senators.
All right, good morning. This is Senate Health and Welfare. It is March 30th, hard to believe. Going out like a lamb, not quite, a little icy today. So this morning, we're going to be looking at a number of bills that have come to us from the House. And actually, the first one we're looking at is getting here very soon, from what I understand. So we've invited Representative Whitman in to introduce H222. And before we do that, Dane, I'm going to have the committee introduce themselves to you so they know you in person.
Good morning, I'm Martine Buick. I live in Burlington and I represent Chittenden Central.
Good morning, Dave Weeks. I live in Proctor and I represent Rutland County.
Ginny Hines, Chittenden Southeast.
Terry Williams. I live in Pulteney and I represent Rutland County.
And Senator Ruth Hardy, who's also on the advisory committee with you, will be in a bit. So welcome, and why don't you introduce yourself for the record and we'll listen.
Okay. So for the record, Representative Dane Whitman, Bennington District 2, and I serve on the Human Services Committee. And today I'm here to talk about H222, which was passed out of the House yesterday. There was one roll call vote prior, and it was 138 to 1 for the roll call vote. And we were able to, get it through Human Services Committee unanimously. Went through the Ways and Means Committee as well, unanimous with this one absent vote, and then Appropriations Committee unanimously as well.
So it came out of your committee unanimously?
Correct.
Yeah.
So we are, the reason we're working on this and the reason we're here is that fatal overdose is an epidemic, essentially. And we've had our third subsequent record-breaking year of fatal overdose. A lot of this has been due to disruptions in our service systems caused by COVID-19, but also due to increased potency of the illicit drug supply, increased contaminants such as fentanyl, which a lot of folks have heard of, but also substances like xylazine, animal tranquilizers, and things like that making their way into the drug supply. So H222 attempts to kind of have an omnibus response throughout many areas of our statute related to treatment, recovery, all the kind of intervention and services that we have. So I'll just go ahead and start walking through what it does. It's very multifaceted, hops around different areas of statute. And I guess what I'll start with is kind of jumping around is it includes extension or making permanent a bill that we passed 2 years ago related to removing criminal penalties for buprenorphine. If you're not aware of what buprenorphine is, it's medication used in the treatment of opioid use disorder. And buprenorphine is a partial agonist, meaning that it activates some opioid receptors in the brain and blocks others. So what that means is that it is enough to satisfy cravings, enough to manage withdrawal symptoms, but it also blocks those receptors so that there's a ceiling effect. So you could take a large amount of buprenorphine and you past a certain point, you wouldn't feel any difference. It's almost nearly impossible to overdose on buprenorphine. And if buprenorphine is in your system and a person uses injection drugs, injecting heroin, fentanyl, it's also near impossible to overdose from that because the buprenorphine actually blocks those substances from affecting the brain. So what we've learned over time is that there are gaps in our formal treatment system. So the interest is if there are a large number of people using buprenorphine that's unprescribed to them, rather than, and as kind of a better means than injection drug use, right? Heroin, fentanyl, but they can access buprenorphine as a safer alternative Previous law treated that as a misdemeanor offense. If you're in possession of unprescribed buprenorphine, it would end up on your record, become a barrier to employment, and it was essentially treated as a narcotic penalty.
Is that compared to, I think we've heard about Suboxone?
Suboxone is a form of buprenorphine.
Okay,
Yep, it's a combination product of buprenorphine and naloxone. Yeah, so that's what it's most commonly known as, but there are other formulations that as well. So we passed this bill from the House 2 years ago. The Senate added a sunset provision, and the governor created an executive order to do a study. We reached out to Johns Hopkins University, and they extensively studied the policy and basically its impact and learning more about how it's affected both the treatment and provider community. If you want to review the Johns Hopkins study, it's full of really valuable information on this policy. And what it mostly found is that, yes, people are, a large amount of people who are engaged in treatment right now may have started with unprescribed buprenorphine. So it was sort of a precursor to them engaging in formal treatment. They tried it, unprescribed to them, and then went from there.
So thank you, Representative Whitman. What I'm going to suggest is just give us the section of the bill that you've added in or changed, because you're giving us a lot of great testimony that I know we're going to have to hear again from others, but I
will move faster. I anticipated this.
I'm terrific.
Always
We'll
happy
have
to-
an opportunity to ask questions at the end.
Yeah,
Okay.
we will. And I think what we'll try to do is try to just look and see what's in the bill. And then we'll ask our witnesses as they come through.
Please feel free to push me along as
Yeah.
I love diving into.
We all
the
get into this mode. I do the
Yeah.
same thing. I was excited about your report.
Great, so sections 1 through 3 of the bill pertain to syringe disposal. Essentially, it's looking at a kind of locally curated model where we add syringe disposal to the Department of Health's current program for prescription drug take-back. And we started a number of regional stakeholder meetings. Because what we found is that it's a really locally curated response where a disposal kiosk might be useful for a community, right? And then we have a small appropriation, $150,000 for communities that engage in those stakeholder meetings can then apply for grant funding to set up a syringe disposal system. It also increases a fee to pharmaceutical manufacturers. It's an evidence-based education and advertising fund, which was started in
My favorite.
Yeah, it's so our understanding is that the fund hasn't been updated in 8 years. It's essentially currently every $100 that Medicaid buys from a drug manufacturer, the drug manufacturer puts $1.75 into a fund that's used for substance use prevention, substance use treatment. It has in statute a number of permitted uses. And this is just this is increasing the fund from $1.75 to $2.25. So just a 50 cent,
How much are you raising it to?
50-cent increase to
Okay,
2.25.
225.
And also in the bill is a syringe services assessment. We know that syringe service programs, huge amounts of evidence that they help people engage in treatment, help people engage in recovery, prevent the spread of infectious disease. But we also know that geographically there's kind of spotty accessibility to services. We heard from a member of our committee who's from Addison County, and it's just a few hours on a Friday afternoon where a mobile van was available, right? Compared to some areas of the state Monday through Friday, 9 to 5. So just we're asking for an assessment to look at what would it cost, what's the feasibility of providing statewide equitable access to syringe service programs. We also modernized our opioid antagonist statute, naloxone. It's about, I think it also hasn't been updated since 2015 or so. And it just had some outdated approaches. I think lately there's been a real push to distribute Narcan, naloxone to people, make it readily available. So essentially, we removed some language that was saying like it needed to be prescribed by a physician in a manner approved by the department, right? This is, I think the FDA just said it was looking at over-the-counter purchase being approved. It also makes some other changes, which I'm sure you'll walk through, but looking to broaden the charge and also open up for some of the more innovative ways of distributing naloxone that's been proposed, like vending machines in a public place that can be available 24/7. On section 5, we update our statute on drug paraphernalia to include other harm reduction supplies in addition to syringe services, needles and syringes. So those syringe service programs that I discussed, they are exempt from drug paraphernalia statute for the needles and syringes that they distribute, right? That's not considered drug paraphernalia when it's the program distributing them. But they also distribute Narcan and fentanyl test strips. So we are just adding other harm reduction supplies to include those as well within their liability protections. So section 6 through 8 all pertain to the different levels of treatment delivery. And we've taken a couple different approaches. Some of it's just updates in terminology, but the main things that we're looking at is prior authorization and trying to make sure that prior authorization doesn't require a procedure that can kind of colloquially be referred to as MedWatch. And we learned about this last year where if somebody comes into a doctor's office, they say, hey, I was prescribed Suboxone, but I had an adverse reaction to it. It made me vomit. Current forms require the doctor to document that and first prescribe to treat the symptoms before prescribing an alternative formulation. And we found that that can be really traumatizing for a patient if they're put in the awkward position of needing to prove that if they take it, they'll vomit. Like we've heard that that happens with providers sometimes. So we're trying to make that clear that that's not required, both for insurance companies and DVA. We've also tied telehealth prescribing for medication for opioid use disorder to federal guidelines. They're a little bit of a moving target coming out of the pandemic. And we are also looking at with prior authorization. Everybody knows what prior authorization is.
Yeah.
Great. Also looking at asking DVA to do a gold card program, which is essentially if somebody has 90% approved, they get the gold card.
And that was a report that came back to us as a result of legislation we passed during COVID.
Yes.
Yeah.
So this is looking at
Okay.
NIT. And then it's also raising the prior auth cap for buprenorphine. Right now, hubs can prescribe to 24 milligrams. Spokes can prescribe only up to 16 before prior auth. So we're making them equal, 24, 24. And that is reflective of federal dosage limits. Good to answer any questions on that.
Okay. I think there might be questions. I'm going to suggest
One
one
more
more thing. Oh, sorry, Representative.
No, it's okay.
Yeah.
That's okay. There's just one more other bit. Recovery residences are
Okay.
also included in the bill. So right now, it's essentially looking to add them, having the right to be permitted as a single family dwelling. This is a right that right now group homes for people with disabilities have. And in fact, people in recovery with substance use disorder fit our definition of people with a disability. But the recovery residences are not licensed by the state. So we needed to sort of spell it out that if you fit these certification guidelines approved by the Department of Health, then you can have the right to be permitted as a skilled manager.
We'll have the department heads right there about that. That's good.
And that's it.
Quick questions for Representative Whitman? Go ahead.
The part about the syringe disposal, what was, can you go back, just briefly go back through that?
Yeah,
Right now, we're getting them at our land, our transfer station.
Yeah.
And we have no way to get rid of them. We're concerned that somebody's just gonna toss them in the compactor.
yeah, no, we've heard the concern in a lot of different areas. And the current Department of Health guidelines are basically to put them in a laundry detergent bottle, duct tape the top, right, recycle. And it's just feel like maybe we can do better than that. And the idea is that we're setting up through the Department of Health and Blueprint are going to host regional meetings where they get together leaders from municipalities, healthcare, hospitals, people with lived experience of injection drug use will also be able to have some feedback, and they're going to look at what are the best practices, what are the best locations, and also how do we think about like rural access. And then there will be a grant program that they can then apply to for the kiosks, disposal costs.
I have two things, but first of all, thank you very much for doing this work. I was so shocked and disheartened to see the numbers that came out recently. So first thing is, in terms of syringe disposal, we go a couple miles over the Canadian border into Canada, and there are syringe disposals, pretty much they're ubiquitous. Is that something that we have looked at doing or replicating their system?
Yeah, so I mean, this is essentially ideally a step in that direction,
Okay.
right? I mean, if a community wants to say, hey, it would be great to have this at the hospital, it'd be great to have this at the gas station, it'd be great to have this here and there, just have that available.
Awesome. And my second question is, have you considered or did you consider putting a drug checking piece into this bill? That is becoming more and more prevalent across the country, and it seems like something that we should be looking at.
So this is like the sort of high-tech drug checking machines that can like analyze the exact breakdown of heroin, fentanyl, xylazine, things like that. We did consider it, and we heard from the AIDS Project of Southern Vermont, who is piloting the program right now in Bennington and Windham County. We just heard about it too late in the process that we weren't able to coordinate with the Judiciary Committee and things like that. So we got this through crossover, not due to a lack of interest in it, but just timing.
Okay, great.
But there was an interest in looking at that and putting it in.
I would say I am interested in it.
For the record,
Okay.
I am also interested in it, so yes, thank
Yeah,
you.
so I know, well, we may be able to pick something up and.
Okay.
Okay, any other questions? Thank you for your work, and I know you've been working with Senator Hardy on the bill, on the advisory committee for our opioid settlement. And so we'll see a lot of that money in here. And then we'll be looking for more money next year. Spend it well, or advise well. We know you will. That's great. Well, thank you.
Thank you all very much.
And we're gonna have Katie come up and go through the bill with us. Just.
Oh, okay, yeah.
Okay.
Hello, good morning. Good morning, Katie McGlynn, Office of Legislative Counsel. So I have, and I know we're sort of short on time. I have a summary, and I thought document, and I know you'll want to go through the language at some point, but maybe for
Let's
the
do
time
the
being, we'll do
summary. Yeah,
the
that's
summary
great.
document. Okay.
Do you, and is there an indication in this where the money is embedded?
Yes.
Okay, that's good. We don't have that up on our webpage yet.
You do.
Oh, we
Is that
do.
your section by section?
It's section by section. Yeah, and then you just pull it up. And No, it is. Yeah, you're welcome. Sometimes it's easier to look at the section by section before you dive into the actual language, gives you a little bit of context.
So
So
it's in our folder right now.
it should be posted for today. That's where I found it. Yep.
Okay, thank you.
So just to quickly walk you through the different sections. In section 1, there's currently a unused prescription drug disposal program. So this would be expanded to include needles and syringes. In section 2, these are the regional stakeholder meetings. It requires the health department and Blueprint for Health to facilitate these meetings regarding public needle and syringe disposal programs. And that by January 15th of this coming year, the health department presents information about, to the policy committees regarding the progress of these meetings. Tied to that is section 3. So there's an appropriation here of $150,000 in fiscal year 24 from the evidence-based education advertising fund to the health department to provide grants and consultations for municipalities, hospitals, community health centers, and other publicly available community needle and syringe disposal programs that participated in the meetings in section
I have
1.
a question about that, so, okay, the evidence-based education and advertising fund,
Mhm.
which is where right now?
That's going to be in section 3A
Oh,
is where our increase is.
Okay, we aren't taking anything from the manufacturer's fee fund for these.
This manufacturer fee, that's the title of the section, but it's the evidence-based education and advertising fund. The title of the section
Okay,
where the change in
just
rate
want to know where the
is.
money is coming out of
Right.
for needle and syringe disposal programs, because if we have sufficient money, if we have sufficient money from the opioid settlement
Mhm,
to that, then we wouldn't want to dip into this for
mhm.
that purpose. That's all. That
Okay.
discrimination.
Nolan can provide more information. My understanding was that the 150, the increase was more than what was needed to cover the 150, that this was
Yeah.
an increase to reflect that it hadn't been updated in a number of
Right.
years.
I'm actually asking a
Different question. Oh, I'm
Yeah,
sorry.
It's okay. It's
Okay.
just where the money's coming from, for the syringe disposal, that could come from another place. And we can use that money in the manufacturer's fee fund for other stuff, that's all.
I hear what you're saying.
Yeah.
Okay, thank you. In section 3B, this is a presentation from the health department this coming February, consultation with stakeholders, to policy committees. And the presentation would contain information about unmet needle and syringe service needs, resources required to ensure equitable access to needle and syringe services, and who's best positioned to provide those services. So that's a presentation. And then section 4 amends our statute pertaining to opioid antagonists. It's an existing section. It makes an amendment to require the health department to include the legal status of possession of substances and harm reduction supplies in any of the education or trainings that it conducts. It requires the health department to distribute opioid antagonists to assist those at risk of experiencing an opioid-related overdose. And it also requires the health department to establish an opioid antagonist dispensing kiosk locations accessible to those at risk of experiencing
So
overdose.
just assuming that an opioid antagonist is like a opioid use inhibitor?
It's like Narcan or naloxone, so that if somebody is experiencing overdose and they're administered Narcan, it's considered life-saving.
Thank you.
Next, this section removes the requirement that a healthcare professional may only prescribe and distribute an opioid antagonist to individuals who have education in a manner provided by the health department. And it also removes the requirement that an individual has to call for emergency services after administering an opioid antagonist. Section 5, this exempts the other harm reduction supplies from the definition of drug paraphernalia, which has the effect of exempting harm reduction supplies from penalties related to selling drug paraphernalia to minors. Then in section 6, we have the title is prescription drug coverage. This prohibits a health insurer or other health benefit plan offered by the insurer or pharmacy benefit manager on behalf of a health insurer covering prescription drugs from using step therapy, fail first, or other protocols requiring documented trials of medication before approving a prescription for the treatment of substance use disorder. This is what Representative Whitman was referring to. The people might have an adverse reaction, and certain paperwork requires that they demonstrate that adverse reaction to the provider, so the provider can say that they have witnessed the adverse reaction. So this language pertains to health insurance, and later on we have language, similar language that applies to Medicaid population. 6A, there's an update. The term medication assisted treatment is being replaced with medication for opioid use disorder. So that change is made there.
Katie, if I could, I'm sure the definitions for the acronyms are in the bill, but what's an SUD and an OUD?
I'm sorry. Yep. The substance use disorder. Yeah.
And an OUD?
Opioid use disorder. So just more specific. Thank you, because it's easy to kind of get in the
You've been
weeds.
doing this for a while.
Well,
this
yeah,
is
no, but
first look.
it's good to pull me back out of the weeds. Okay, so 6B, this amends the existing rulemaking authority to provide the health department and DEVA with greater flexibility in maintaining a regional system of opioid use treatment. The language is more expansive as to who may dispense substances to treat opioid use disorder. For example, it replaces a physician or APRN with a healthcare provider, which is a broader term. It adds a new subsection D to allow controlled substances for use in opioid use treatment to be prescribed via telehealth in accordance with federal requirements. During COVID, federal requirements were relaxed in terms of use of telehealth, and now there's proposed rules in place to make that permanent. Where the proposed rules will finally land, we don't know yet, so this just says that it will be in conformity with the federal requirement. This adds a subsection E to provide to prohibit DEVA from requiring a healthcare provider to document the patient's adverse reaction. So this is the second sort of pair with regard to preventing documentation of that adverse reaction. So this applies to Medicaid. Section 6C, this is again updated language instead of MAT, medication for opioid use disorder. Section 7, medication for opioid use disorder. This requires AHS to provide coverage to Medicaid beneficiaries for medically necessary medication for opioid use disorder when prescribed by a healthcare professional practicing within the scope of the professional's license and participating in the Medicaid program. And then pending approval from the Drug Utilization Review Board, this requires AHS to cover at least one medication in each therapeutic class for methadone, buprenorphine, and naltrexone as listed on Medicaid's preferred drug list without requiring prior authorization.
So now we're gonna have to say, mood instead of MAC.
I know, it doesn't roll off the
It
tongue in the
doesn't
same
roll
way,
off
no.
as easily.
Yeah, yes. Section 8, we have by November of this year, the Joint Legislative Oversight Committee looking at recommendations regarding legislative action needed to ensure continuity of treatment for individuals who are re-entering the community after discharge from a correctional setting, including eliminating prior authorization for medication for opioid use disorder. Then we have a report in 8A. This is the Gold Card program. So first, it requires DEVA in consultation with individuals with diverse professional perspectives to research the feasibility and costs of administering a Gold Card program for substance use disorder treatment, in which AHS shall not require a healthcare provider to obtain prior authorization for substance use disorder treatment if, in the most recent evaluation period, the agency approved or would have approved not less than 90% of the prior author requests submitted by that healthcare provider for the medication. So DIVA's research would be submitted to the Drug Utilization Review Board and the Clinical Utilization Review Board for further review and related recommendations. So that would be by December of this coming year. And then by next April, I have the wrong date in the section by section summary, but not in the bill. So it's 4/1/24. The two boards would submit respective recommendations to Human Services and Senate Health and Welfare about this gold card program.
Do you want to talk about the gold card program now, or should we hold off and wait till we have some testimony?
Why don't you have some testimony?
Yeah, okay.
Thank you. Section 8B, I should flag that this is a section that will require money. The last I knew from Nolan, and I know Nolan's on, so he can correct me if he has updated information, that the number hadn't been settled on yet about the cost of this. But this language directs DIVA to amend its rules to enable a healthcare provider and office-based treatment programs to prescribe 24 milligrams of buprenorphine without prior authorization. Right now, they're allowed to do 16 milligrams, but hubs are allowed to do 24. So this brings hubs and spokes able to prescribe the same level without prior authorization. Section 9, this is the recovery residences. So this language requires that in all municipalities, a recovery residence serving not more than 8 individuals be considered by right to constitute a permitted single-family residential use of property, and it adds a definition of what we mean by recovery residence. We have a repeal section. This removes the future repeal of buprenorphine exemption, meaning that if it was passed, the section would be a continuation of existing law in that there would not be criminal penalties for possession of 224 milligrams or less of buprenorphine, and there are exceptions. Persons under 21 years of age in possession of 224 milligrams or less would be referred to a court diversion program for the purpose of enrollment in a youth substance awareness and safety program. And persons under 16 years of age in possession of 224 milligrams or less are subject to delinquency proceedings in the family division of the Superior Court. So this repeal sort of maintains the status quo right now. And we have everything taking effect on passage except the section on medication for opioid use disorder takes effect September of 2024.
Okay. We'll just do some quick questions now, and then we'll try to bring some testimony and to fill out what's here.
Section 9, who in the municipality is gonna, who's gonna enforce that? Who's gonna make sure that that residence is actually meeting compliance and requirements?
I think that's a better question maybe for the League of Cities and Towns when they come in about what kind of enforcement they currently do. This is adding on to existing language that's already in statute. So I'm sure there's already a structure or protocol by which this type of enforcement happens.
Okay.
Yeah, good question. Okay, any other questions for Katie? There's a lot here. And as we go through, we may be modifying some of this. We've already seen one place we might want to add something. And I might have a suggestion for something else. So we'll just, this looks like a Christmas tree already. Okay. Thank you. This is great. So this is our first look, and we won't get the bill until Tuesday?
Tomorrow. I think
Is
tomorrow.
is today the third reading?
I think so.
Yesterday was.
Oh, yesterday it was?
Yeah.
So we will get it. We may get it as early as today. Okay. All right, so finally. All right. So we're going to move on on our agenda. So coming up, we're going to have three or four compact bills that are coming to us. And this is the first one. So Representative Rebecca is here. Why don't you give us, we know how what these are like. Some of us have been through compacts before, but if you could just give us a couple of things. One, what was the vote in your committee, the vote on the floor of the House, and then generally what's in the bill and the value that you see in the bill.
Okay, and Katie's gonna do a walkthrough.
Yes, yeah,
Okay.
she's gonna, you don't have to do that.
Okay, I'm not gonna walk through the bill, but I will tell you a little bit about
Sure.
the,
And before you do this, we're gonna introduce ourselves, just so you know each person.
Ruth Hardy. Nice to see you.
Terry Williams, Rutland.
Jenny Lyons.
Dave Weeks, Rutland.
Martine, hello.
We know
Okay.
each other.
I never know who knows whom.
Freshman
That's all.
class.
Yeah, okay.
That's right. And we're the only
Yes.
ones who haven't. Yeah,
Yeah,
and I'm Representative Rebecca and I represent Winooski.
Thanks.
First term.
Morning.
Good to know.
Okay.
You got
So-
to get t-shirts in your class.
I know, right?
Yeah.
Good idea.
Right.
Old
Tattoos.
home week. So why don't you introduce yourself officially for the record, and then we'd enjoy listening to your presentation on H62.
Officially for the record, Representative Daisy Rebecca, and I'm here representing the Committee on House Healthcare. So I'll be speaking about H62, which is an act relating to Vermont joining the Interstate Counseling Compact. This is the first of several occupational compacts that we've passed in the House. And I think today you'll hear from two more healthcare members who will be talking about other occupational compacts. So I understand that most of you are familiar with the structure of these compacts and that they are generally an agreement that's made between multiple states. In this case, 16 with an additional 18 that have legislation in play right now to join the compact. So there's not a lot of the language that we can adapt for our state. Section 2 in the bill, when you do your walkthrough, you'll notice does address background checks and things like that, which we worked on the language with OPR. So that adds what we're already doing in Vermont as far as background checks to the language of this particular compact. But other than that, there's not a lot of changes that we can make in the bill. So it's pretty straightforward. And the same goes with the other compacts that you'll discuss today. Go ahead.
Do background checks include fingerprinting?
Yes.
I understand there's a lag, a significant lag in fingerprinting. Would that negatively impact the ability for the program to roll smoothly?
So OPR can speak to that.
Okay.
Because not all of the occupations get fingerprinted, right?
Okay.
So it's different depending on the profession. So this particular compact, the Interstate Counseling Compact, is actually for mental health counseling, which we all know. I mean, most of us are acquainted with counseling and hopefully here in part due to that profession. But I think especially because the COVID pandemic really exposed some of the inequities in people's access to it, this compact in particular is one that's near and dear to a lot of people. I think it's really going to improve access to those services. I think it's going to expand the profession. For example, it expands people's ability to practice out of state. And also if there is, as you mentioned, kind of a backlog with a lot of things right now as we're catching up after the pandemic, it expands the ability of practitioners to practice beyond barriers. So we would be someone's home state if you're licensed in Vermont, but you can also join the compact and get a compact license with the right to practice, a privilege to practice in a compact member state like Ohio. And if you have that privileged practice in Ohio, you basically have license reciprocity. And then if you have a client in Ohio, you can practice there. So it not only benefits, say, a client you have who leaves Vermont for college in Ohio, you can continue your client relationship with them, which is great for healthcare outcomes to extend that relationship. It also is good for the practitioner to continue to have some say on their caseload and predictability on their caseload. And it's also great for that client. So I think this is going to extend our ability to, when you can't get a mental health counselor in Vermont, you can also reach out to practitioners who have joined our state compact, right? So if we're on that list and someone in Ohio wants to be able to practice in Vermont, they can pay a fee to be able to practice here.
Good, thank you. Go
Is
ahead.
the intent to create the compact, or I'm not sure if it even exists now, or to extend the compact to those states that surround us, or basically just to throw the net wide and incorporate as many states as possible? What's the real intent?
So already part of this compact arrangement are most of the states around us: Maine, New Hampshire, Delaware, Maryland, West Virginia, Ohio, North Carolina, Tennessee, Georgia, Florida, Alabama, Mississippi, Louisiana, Utah, Colorado, Nebraska, 18 other states.
Okay.
So we're kind of joining along with most of the nation, actually.
This may be too complicated to address right now, but I'm kind of still new to compact stuff, the whole
Katie's gonna go through the
concept. No, I know,
Yeah.
but I'm just wondering what the interplay is between compacts and health insurance. And again, that may be too big to cover right now. Okay,
Well, hold that thought.
okay.
That's good.
So maybe I can walk through how it really is going to benefit some of the residents, because I think that's probably what's most important. I know Katie can get into some of the technicalities of the legislation, but I think it's going to increase, like I mentioned, the portability for practitioners, because it allows the member state regulatory boards to better protect people. So it really protects some of the ways that we've already built into our laws. The enhanced sharing of licensure information, OPR will speak to that. Existing interstate occupational licensure compacts have also been successful in reducing barriers for practitioners who want to provide services in other states. They've demonstrated increased access to care. So like I mentioned, if you live in Vermont and you need a mental health counselor, but there's a wait list, which is common, you can use services of a counselor who's licensed under the compact from another member state. They've improved quality and through continuity of care when clients or counselors relocate. This is an important one. Military personnel and their spouses often relocate. And when that happens, if you're a spouse and you're a counselor, you lose your license, and without reciprocity, it's an arduous process to get all your clinical hours and get relicensed in another state. So this actually really supports families in a really critical way. Another one is preserving and strengthening the current system of state licensure in every state. And this does that through preserving the state's authority to regulate these professions. Counselors who utilize the compact, they have to abide by the laws and rules of the state that they're practicing and adhere to that state's scope of practice. So there are, the state that you're licensed in is the state that will be responsible for disciplining someone if there's ever an issue of discipline. So even if you are here, but you join the compact and you're practicing in Ohio, Ohio cannot discipline you for something, and you'll notice that this comes up, and Katie can speak to this, but around the post-ops world, that becomes an important issue. So unlike national licensure initiatives that really can supersede some of the state regulatory authority, the interstate compact actually allows member states to continue to determine the requirements for licensures in the state, as well as maintaining the state's scope of practice for all the professional counselors that practice here in Vermont, whether that's through a state issued license or through the privilege to practice that they're calling it in this compact.
Thank you.
I think the last thing that I would mention is this won't impact any currently licensed mental health counselors. They don't have to join if they don't want to. So there will be no additional fees to them. If they don't feel like they want to change the way that they're operating, or they don't want to extend their practice to serve people in New Hampshire, they don't have to. So that's important.
Okay. So can you tell us who this covers? Is this, does it cover social workers or does it cover only, MH mental health counselors? master's level,
LMHCs.
And master's level counselors?
Yeah.
Okay.
What does LMHC?
Licensed mental health counselors. Yeah, and we'll have, well, the other two folks coming in this afternoon will have other professions, and then on next Wednesday, we'll be doing this like compact, which will be for psychologists and
Are we getting that?
yeah, I think so.
Okay.
I hope, I'm crossing my fingers, it hasn't passed yet, but I'll be
Is it on
presenting
the
it.
calendar for that? Is it? Yeah, okay.
Yeah.
I sort of remember seeing that. Okay.
Yeah, it is. So I hope I gave a good enough intent.
This is great.
The
This is very
compacts
good. I
that
appreciate it very
Improving
much.
access for professions, especially for mental health professions, I think.
Right,
is
and
critical.
we've heard about that as we were looking at telemedicine, telehealth, and especially for college students.
Right,
Yeah, so going out of state could be the same coming in state, so. we appreciate
Exactly.
it. That's good. Okay,
thank you.
thank you.
Good to meet you.
Nice to meet you as well.
Katie,
Can I make a comment as we're in transition here?
sure.
I just wonder what impact this will have, given that it seems as though there's a capacity shortage in mental health care providers, and I think it's nationwide.
Mhm.
I mean, I'm hopeful that it'll help, but it just seems like we need more folks doing the work kind of across the board.
It will, and it'll have to, it's interesting because we'll have to have OPR and look at the relationship between what OPR is doing on temporary registrations and then the more permanent licensure program they're gonna have and how it fits with the compact. And I don't know if that question has been asked anywhere. Did you talk about that in healthcare at all? About what the programs that OPR is putting in place for out-of-state folks being licensed? Probably not.
No.
Okay, all right, well, we may look at it. We'll see if we have to. I'm not sure it's a conflict. Thank you.
Thank you. Katie McGlynn, Office of Legislative Counsel. Since you will be seeing several compacts come through today, I'll just start there. So compacts are voluntary agreements. States don't have to enter compacts. States may choose to enter into a compact. The compact language is provided to states that are interested in entering the compact, and all the states adopt what is essentially identical language. There might be different numbering depending on how their statutes are structured, but in terms of the words, we're really not making changes. It's sort of an up or down vote by the state as to whether you want to enter the compact and this is what the compact is or not. That is sort of unique to compacts. Vermont has entered other compacts in the past. You don't have to stay part of a compact. A state can leave a compact, and most compacts have language in them that gives the process for how to leave a compact, and this compact is no different in that respect. It would involve a legislative process. So much like the process to adopt it, there could be a process that would have to go through both chambers. It would be a bill that would move through that they'd want to leave the compact. And after the legislature would vote to leave the compact, I think there's a 6-month period between when that legislation is enacted and when the state would formally be out of the compact. So that gives you sort of a framework. This particular compact, as has already been noticed, it talks about licensed professional counselors, and it notes that in every state, they may be referred to differently. So in our state, our licensing statute calls them a clinical mental health counselor, but that's what is meant in the compact when we say a licensed professional counselor. And again, different compacts are structured in different ways. When I think of this compact, I think that this sort of gives Vermont licensed professional counselors kind of a fast track option to practice in other states, other member states of the compact. So if you were a Vermont practitioner and you want to practice in another compact state, you would apply to the compact commission and state your intention. You might have to pay a fee to the commission or to the other state. States can determine if they want there to be a fee for participants from other compact states who wish to practice in their states. And then you'd sort of have a fast track to practice in that particular state. You'd have to be licensed in your home state, so you'd have to be licensed in Vermont to make that application and to get that license. So you're not, just because Vermont enters the compact and you are a licensed mental health counselor in the state, that doesn't mean you're suddenly licensed in all the other compact states. You still have to apply, and you apply for a specific state or states that you want to be practicing in. There is a structure for each of these compacts, like a governance structure. So this one has a governance structure in which there is a delegate from every state that is a member of the compact that sort of sits on a governing board. This board or commission, they can adopt rules, much like we have a rulemaking process, and rules sort of carry the same weight as the law. This board can adopt rules related to the compact, and the states or abide by those rules that were entered into. And there's some language that if, you know, a majority of states, if their legislative bodies say we disagree with the rule, then the rule can't stand. But otherwise, the states are bound by the rules adopted by the kind of governance system for this particular compact. So that's a high level overview. It is, as all the compacts are, they're fairly detailed and they're fairly long. I have a section by section summary, which is still dense. It's 6 pages and it's a dense 6 pages. So I'm happy to go through it.
Way to
And I
sell it,
also,
Katie.
well, I'm just
Something
wondering.
to look forward to.
I know, sorry.
Let's go.
This is all to say, I know you have 4 minutes left, so where would you like me to go? I can start going through it,
Yeah,
or
let's
I
just, you
can.
know, and you can raise that level over the section by section even higher.
Even higher, okay.
Yeah, that would be good.
The
Let's see.
agenda says we've got till 10:30, doesn't it?
Yeah.
Oh, I thought you only had till 10.
Thanks.
No, we have
Thanks,
till
Mark.
10.
Sorry.
Worried about that? Thank you.
Oh,
Thank you, Sandra.
is that right?
Yeah, you're good.
Oh,
The
we're
chair-
very good.
chair
It is
will tend to
actually
get
important
salaries.
for you guys to understand how compacts work.
Yeah.
Yeah.
So
it's
we'll-
really- it's
and-
really-
I thought I only had 4 minutes. I
No,
have a
no,
half
no,
hour,
you
so
have-
Oh my gosh, you
we
super detailed.
we can get very detailed now.
I did anticipate that this would take a little longer.
Okay.
Hang on a sec, Senator Williams.
Just, can we go back to, what's the genesis for this bill? I mean, was it requested by medical society because we have the need for mental health counselors and we don't have much?
So
Kind of curious.
Who introduced the bill, I guess, and
I
how
think
did that
it was
come about?
Representative Cohen. I'd have to go back and check. I'm pretty sure it is.
You
So,
wanna talk?
oh, that would
Yeah.
be better.
Yeah,
Yes.
Representative Houghton introduced it, and I would let her speak too.
Sure, well, we'll ask her, maybe we can have a conversation with her.
Can I read this piece of
Yeah.
Sure.
It could be the mental health counselors.
Are they all
themselves who
one
advise
page?
us.
Yeah, okay.
Okay, so I'm going to share my dense document with everyone. Okay. So, the first section 1 of the bill that came over from the House is the compact. You'll notice there are other sections of the bill. They represent amendments that were made on the House. And I want to be clear because I just said that we can't amend a compact. The amendments that were to this bill were not to the compact language itself. But you can have amendments outside of the compact that sort of pertain to the compact. So in this case, there are amendments outside of the compact. The compact was not, of course, amended, but there are amendments about Vermont charging fees to folks who are participating in compact states who want to practice in Vermont. And there is an amendment about fingerprinting, having authority to fingerprint, which is a requirement of being part of the compact. And I will say, if you decide to move forward with this, another amendment that would need to happen is usually we have the statutory and acting language, like a sentence that says affirmatively, the state of Vermont is adopting the compact, and we don't have that in the bill. So we'll have to have an amendment with that sentence outside of the compact. Okay, so section 1 is the compact. First is the purpose section of the compact, which is to facilitate interstate practice of licensed professional counselors to improve access to professional counseling services. Professional counseling occurs in a state that the client is located at the time of counseling, and compact states retain the regulatory authority to protect public health and safety through the existing system of state licensure. And then it lists the compact objectives, which I don't have listed out. There's a large definition section in this bill. And I didn't pull all the definitions out, but just a few to give you a sense. So the commission is the national administrative body, and the membership of which is all of the compact states who have chosen to participate in the compact. We talk a lot about an encumbrance on a license. It's the revocation, suspension, or limitation of full and unrestricted practice of a professional counseling license by a licensing board. We talk about the licensed professional counselor. What does that mean? It's a counselor licensed by a member state, regardless of the title used in that state, to independently assess, diagnose, and treat behavioral health conditions. And then,
Can I ask about that?
Yeah.
So I'm just looking at your summary, not the bill itself, but so I was curious about the scope of counselors. Does it include like psychologists, psychiatrists, social workers?
it's
all of that?
limited. It's limited to clinical mental health counselors.
Okay.
And then the practice of professional counseling is the assessment, diagnosis, and treatment of behavioral health conditions by a licensed professional counselor. So then in 3275C, we have a list of what is required for a state to participate in the compact. So a state must license and regulate licensed professional counselors, require licensees to pass a national exam approved by the commissioner, require licensees to have 60 semester hour or 90 quarter hour master's degree in counseling or graduate coursework in a specified topic area, require licensees to complete a supervised postgraduate professional experience as defined by the commission, and have a mechanism to in place for receiving and investigating complaints about licensees.
So the postgraduate professional experience that's being defined by the commission, how is that different from what our master's level folks would have in this state? Is there something different that's being required?
I would ask you to save that question for OPR.
I will
I
do
don't
that.
know. So a list what member states are required to do. They have to participate in the commission's data system. So the commission has a data system that contains all of the information about licensees who are practicing under the commission.
How
Under the
available is that data system? Is that secure? We don't
More,
know that one either.
more
Okay.
questions
Yeah,
for
that's,
OPR.
yeah, okay.
Or for the compact commission itself. I don't know
Yes.
if you could have somebody speak to you from the commission.
Well, if it has names and all that stuff.
Member states have to notify the commission of any adverse action or the availability of investigative information about a licensee. Member states have to implement or utilize procedures for considering the applicant's criminal history records. They have to comply with the commission rules. They have to require applicants to obtain or retain a license in the home state and meet the home state's qualifications for licensure renewal. They have to grant privilege to practice to a licensee holding a valid unencumbered license from another state in accordance with the compact rules. And they have to provide for attendance of the state's commissioner at counseling compact commission meetings. So the state's commissioner is usually, I don't know, probably in this case, it'd be somebody from OPR or from the board that regulates mental health clinicians.
So, and just to clarify, we have one person in the state who is goes to the sort of the central location
Mhm,
for the total compact.
mhm.
And then we have individuals who represent individual compacts, or does that one person represent all of the compacts?
I think it probably depends. There's no requirement that the same person in the state sits as a commissioner for all the compacts in practice. If it's somebody at OPR who regulates professions, that might be the outcome, I'm not sure. But there's no requirement that the same person
Okay,
serve that
just
function.
wanted to. look at
Yeah.
that,
Let's see. It allows member states to charge a fee for granting privilege to practice in their state, which the House has elected to add a fee. This allows individuals not residing in a member state to be able to apply for a member state single state license. But a single state license granted to these individuals shall not be recognized as granting privilege to practice professional counseling in any member state. The compact does not impact the member state's ability to issue a single state licensure, and the license issued to the professional counselor by a home state to a resident state, and that state shall be recognized by member states as authorizing the licensed professional counselor to practice professional counseling in each member state. So then we move on to what is privilege to practice. So to exercise the privilege to practice in a remote state, the licensee has to meet the following requirements. They have to hold a license in their home state, have a valid social security number or national practitioner ID, be eligible for privilege to practice in a member state on the basis of certain criteria being met in this section. They cannot have any encumbrance or restriction against any license or privilege to practice within the preceding 2 years. They have to notify the commission that the licensee is seeking privilege to practice in a remote state. They have to pay applicable fees, including potentially state fees if the states have elected to have fees. Meet continuing competence and education requirements of the home state. They have to meet any jurisprudence requirements of the remote state or states in which the licensee is seeking privilege to practice. And they have to report to the commission any adverse action, encumbrance, or restriction on a license by a non-member state within 30 days of that occurring. In terms of privilege to practice, it would expire in a remote state when it expires in a home state. So you must have an up-to-date home state license. Licensees who are providing professional counseling in a remote state under the privilege to practice must follow the law of the remote state. Licensees providing professional counseling in a remote state are the subject to the remote state's regulatory authority, which may include removing the licensee's privilege to practice for a period of time, imposing fines, or taking other action. The licensee may be ineligible for privilege to practice in other member states until the time period has elapsed and the fine is paid. If the home state license is encumbered, the licensee shall lose privilege to practice in remote states until the home state license is unencumbered and the license has not had an encumbrance or restriction against a license or privilege to practice within the preceding 2 years. The licensee may lose privilege to practice in other remote states if the privilege to practice is removed in any other remote state. So see, there's difference of a shall and a may there, depending on where the license is encumbered. And again, until a period of time has elapsed, fines are paid and licensee has not had a restriction or encumbrance in the preceding 2 years. So that brings us to page 3, obtaining a new home state license based on privilege. So a licensed professional counselor can only have one home state at a time. And this section details the process by which a licensed professional counselor could change their state of residence from one member state to another. If a licensed professional counselor changes their state of residence by moving from a member to a non-member state or vice versa, the state criteria shall apply for a single state license versus participation in the compact. And the compact does not prevent a licensee from holding multiple single state licenses. But for the purpose of the compact, there's only one home state. And the compact does not impact the state's ability to issue a single state license or requirement related to the single state license. As was mentioned earlier, there is a section pertaining to active duty military personnel or their spouses. And this specifies what is considered a licensed professional counselor's home state, while the counselor or the individual spouse is on active duty. Next, there's language about practicing via telehealth. Member states shall recognize the right of professional licensed counselors to practice professional licensed counseling in any member state via telehealth under privileged practice. A licensee providing professional counseling services in a remote state shall adhere to the laws of the remote state. And then we have what constitutes adverse actions. So a remote state has authority to take adverse action against licensed professional counselors privileged to practice within that member state and issue subpoenas for hearings and investigations requiring attendance and testimony of witnesses and production of evidence. Only the home state can take an adverse action against a licensed professional counselor's license issued by the home state. So only the home state licensing authority can take away a home state license.
But a distant state can take away the compact license, or,
They can choose to take away the privilege to practice in their state.
okay,
Yeah,
that's it,
yeah, but they can't take away the person's license in their home state.
right.
With regard to taking adverse action, a home state shall give the same priority to the reported conduct as received from a member state, as if it were occurring in the home state. So if a member state reports misconduct to the home state investigates as if it happened in state. Let's see, a home state completes any pending investigations of a licensed professional counselor who changes primary state of residence mid-investigation. The home state is authorized to take appropriate action and promptly report investigations to the administrator of the compact data system. The administrator of the coordinated licensure IT system shall promptly notify the new home state of any adverse actions. The member state can take adverse action based on factual findings of a remote state. It provides guidelines on joint investigations between member states. If adverse action is taken by a home state, the licensed professional counselor is privileged to practice, and all member states will be deactivated until all encumbrances on the home state license are removed. The compact does not prohibit a member state from participating in an alternative program in lieu of an adverse action. Okay, so we're halfway through. I know it's dense, but we're getting through it. Yeah.
Very great.
Okay, so at the top of page 4, establishment of the Counseling Compact Commission. So this is the governance structure for the compact itself. So this creates the Counseling Compact Commission. It's a creation by member states, provides for venue for judicial proceedings brought by or against the commission. It shall be brought where the principal commission's office is located. Each member state has one delegate selected by state's licensing board, who is either an administrator or a member of the licensing board. The commission will meet at least once annually, and then there's a list of the commission's duties. So to establish the commission fiscal year and bylaws, to maintain financial records, to take actions consistent with compact and bylaws, to promulgate rules which are binding on compact states. It's responsible for handling legal proceedings. Oops.
Sorry, I just have a question, as someone who's just new in this world, but so maintaining financial records, what kinds of finances are associated at that sort of compact commission level?
It could be lots of things. It could be maintaining their office space. It could be hiring employees. It could be maintaining the data system. It could be fees paid for people who are participating in the compact and who are seeking a license. They may have to pay a license. So it's sort of business expenses and fees coming in, could be broader than that.
And just a comment, this section of the bill, or at least a lot of the governance stuff, we always ask GovOps to look at and to make recommendations, if any. So I'm looking at Chair of GovOps.
Okay.
But so it's true for each of the compacts. It doesn't have to, you don't have to take it in necessarily unless you see something egregious, but but it's really helpful to have GovOps go through it for us.
Okay, will do.
Okay.
Senator Hardy will look forward to this presentation. the second time.
Can't wait.
And it's every one of these, so once you start on one, the others, that'd be great. Okay.
Okay, so we're still on the list of commission duties. Let's see, promulgating rules, handling legal proceedings in the name of the commission, purchase and maintenance of insurance and bonds, borrowing, accepting, or contracting for services, hiring employees, electing and appointing officers, fixing compensation, accepting donations and grants, leases, purchases, and acceptance of gifts, managing commission property or acquisition or disposition of property, establishing a budget, making expenditures, borrowing money, appointing committees, including an executive committee, providing and receiving information in cooperation with law enforcement agencies. The section describes the duties of the executive committee. It outlines the requirements for commission meetings. It outlines how the commission is financed, and it describes immunity from suit and liability for members, officers, and employees. Next, we have a section on the data system. The commission is to provide for the development, maintenance, and operation and utilization of a coordinated database and reporting system pertaining to licensure, adverse action, and investigation information on all licensed individuals and member states. Member states are required to submit uniform data to a data system. Member states contributing information to the data system may designate information that may not be shared with the public without express permission. Any data submitted that is subsequently required to be expunged by the laws of the member state shall be removed from the data system. And we have language on rulemaking. So this authorizes the commission to adopt rules and amendments to rules within the scope of the compact's purposes, which are binding on members. If a majority of the state legislatures of member states rejects a rule adopted by the commission in the same manner as it has adopted the compact, the rule shall not be in effect. This describes the process for proposing and promulgating rules, including notice and opportunity to be heard requirements. And it describes the process and criteria for promulgating emergency rules.
So this means that, we need to circle back and look at what the rules are and how they affect our policies in the state. Anyway, and the next thing is oversight, though.
Oversight, yeah. So this section directs the executive, legislative, and judicial branches of member states to enforce the compact as it has the standing of statutory law. If the commission finds a member state has defaulted on the performance of its duties under the compact or rules, the commission shall provide written notice to the defaulting state and other member states of the nature of the default and a proposal for curing the default and providing remedial training and technical assistance to the state. A state that fails to cure a default may be terminated from the compact on the majority vote of the member states. The commission is not responsible for costs related to a state that is in default or has been terminated. A defaulting state may appeal commission action by petitioning to the U.S. District Court of the District of Columbia or the federal district where the commission has its federal office. A member state can request to attempt to resolve disputes with the commission via a dispute resolution process, and the commission enforces the provisions of the compact. Terms of date of implementation of the counseling compact. and associated rules, withdrawal from the compact and amendments. The compact is in effect when the 10th member state signs. We already have 10 states, so the compact.
So this one's already up and running.
Yes, but let's clarify that point. There's a nuance to that.
Okay,
I think they have the 10 states that they need, but it's scheduled to take effect a year out maybe at this point.
okay.
So I've forgotten the details on that, but OPR will have that.
Okay.
Member states that join after the compact is in effect are subject to rules in effect when the state joins. Member states may withdraw from the compact by repealing the statute. The withdrawal doesn't take effect until 6 months after enacting the repealing statute, during which time the member state's professional counseling licensing board has to continue to comply with investigative and adverse action reporting. The compact does not prevent a cooperative arrangement between a member state and a non-member state. Construction severability, the compact is construed liberally to effectuate the purposes, and severable if any provision is found invalid. Binding effect of the compact and other laws. A licensee providing professional counseling services in a remote state under privilege to practice shall adhere to the remote state's laws and regulations. The compact state does not prevent enforcement of any other member state law that is not inconsistent with the compact. The compact supersedes laws of a member state in conflict with the compact. And if the compact exceeds the constitution of a member state, the provision in question shall be ineffective with regard to that specific provision.
That's not.
So, yeah. So that's the compact piece. We've made it through. So now we have amendments added by House committees.
Okay.
So first there was an amendment. This is in a section pertaining to the duties of OPR, and there's a list of professions for which OPR may inquire into the criminal background histories of applicants for initial licensure or licensure renewal. So we're adding to that list, licensed clinical mental health counselors, licensed marriage and family therapists, and individuals registered on the roster for psychotherapists and non-licensed and non-certified, who are non-licensed and non-certified. So that lists an inquiry into
That has
criminal
nothing to do
background.
with the compact, it's only, or does it?
It is to the extent that the compact says that
No.
licensed professional counselors, the state has to have a way to check criminal background. And so this gives that authority with regard to clinical mental health counselors.
Okay.
Next is the fees. So section 3 requires that a licensee of a remote state under the counseling compact has to pay a biennial $50 privilege to practice fee. And then we have effective dates. So sections 2 and 4. So the effective date section and the background check section takes effect this coming fiscal year. And then 1 and 3. So the compact itself and the fees related to remote privilege to practice don't take effect for a year out, July 1, 2024.
Okay. Questions for Katie?
Nicely done.
Well done.
Yeah.
It is, it's a lot, and there's a lot here, and the more we go through, the more we see some similarities, but then we also have questions because they're about different professions. Senator Harvey has a question.
Thank you, Madam Chair. I'm trying to get to this section and I know the chair is interested in this as well, but the what is it called? An encumbrance on somebody's license. If as this relates to our work in S37.
I was gonna bring that up later, but.
Oh, later, okay.
Yeah,
If
let's
you'd
hold
rather,
off on
it's
that, please,
fine.
yeah.
Yeah, I think it's relevant to all of the compacts.
Well, there's a lot that's relevant. There's also the language that we have on conversion therapy that is relevant. So it's what I sent you in my note was S37, but we also have other laws that protect citizens in the state, including juveniles. But you're right. Make a comment.
Yeah, I think the same question applies to all of the compacts. In this case, if somebody had privilege to practice outside of the state and they were complying with Vermont law, but not with that state's law, they, under the compact, they have to comply with the remote state's law. So the state, the remote state could remove their privilege to practice. And they would have to explain to the home state why. The home state could choose to discipline or to take away a license, but they're not required to take away a license.
So, but the language in the compact says that there's something about legal action, a lawsuit, but it's only related to the ability to practice, or can it go further? And I guess that's a broader question, and that was a question I was going to bring up in conjunction with some of our unique laws.
I have to take a look specifically where you're looking, but my recollection is the same part of the duties of the commission is that they would manage any litigation against the commission, or that the commission chooses to bring, on behalf of the commission. I will say, and OPR also spoke to this in House Healthcare Committee, so I might recommend that this is a committee.
We'll
A
have
question
OPR.
this committee have OPR address this. I just lost my train of thought.
Litigation compact
Litigation
against
compact.
the
Well, I
licenses.
guess more specifically, so if there are 10 states and somebody does something that is against one state's rules,
Mhm.
and they lose their privilege to practice in that state, does it automatically mean they lose their privilege to practice in the other 9 states? if
Oh,
it's-
I see.
We'll ask.
I don't have an answer to that. My instinct is no, that each state is making the decision, but I will confirm that.
Okay,
And I remember what I was going to say, was that I think a lot of compacts right now are sort of grappling with these issues.
yeah.
And, I've asked our student clinician to go through all of the meeting minutes for this compact to see, has there been conversation about this issue? And the only conversation so far has been raised by our own OPR as an outside party, because we're not a member to the compact. But having a seat in the compact, gives an opportunity to raise those issues maybe.
So, yeah, so Senator Hardy was bringing up a question. I sent a note suggesting that we need to include the language that we put into S37 as part of each of the compacts that we look at. It might be modified a little bit. You didn't do S37, so you don't know what the language is maybe,
Yeah.
but I think we should look at that and maybe extend it further in terms of what we have in legislation, in particular this one, where it's counseling, because we do have language on conversion therapy in our statutes. So it's just, this gets very complex when we see other states in a different place, that's all.
One other clarifying question. So if a provider practitioner loses a license to practice in a compact state, it's not his or her home state. It's investigated by the home state, right? And it doesn't necessarily mean that you lose your license in your home state.
Correct.
Right.
Thank you.
That's fun. Okay, so we'll dive into this further. We'll have testimony and we'll be able, I think OPR will probably provide us with the greatest clarification on some of the questions that we have going forward. All right, so we're going to go off live, Alex, for just about 5 minutes, and then we'll come back and look at the other 2 compacts that we have.